The essential principles of evaluation and management pathways in prenatally detected fetal anomalies. Vivek Parmesvara Sarma. Introduction. The evaluation and management of prenatally detected fetal anomalies constitute a challenging problem. The optimal outcome for the fetus and the mother depends on the accurate diagnosis, appropriate evaluation, and informed, scientific decision-making regarding prenatal, perinatal, and postnatal management. The recent advances in prenatal diagnosis and widespread adoption of fetal imaging have increased the detection of fetal anomalies. The availability of maternal screening investigations and newer methods of genetic testing have further added to the diagnostic spectrum. The abnormalities can range from minor alterations of uncertain significance to major defects with grave prognosis. The inputs of multiple specialists are required to ascertain the severity and prognosis of an anomaly and the need for fetal diagnostic and therapeutic modalities. The decision regarding termination of pregnancy for fetal anomaly and need for advanced perinatal therapy or changes in obstetric management are also vital in this regard. The article is designed as a narrative review on the broad topic of prenatally detected fetal anomalies, with the aim of summarizing and synthesizing clinically relevant information from literature. The aim is to review the common prenatally detected fetal anomalies with regard to their diagnosis, evaluation, and management principles. The article aims to analyze the complexities in evaluation and management of prenatally detected fetal anomalies and highlight the challenges in therapy, while formulating and elaborating the scientific approach to treatment. Main text. The evaluation and management of prenatally detected fetal anomalies constitute a challenging problem. The optimal outcome for the fetus and the mother depends on the accurate diagnosis, appropriate evaluation, and informed, scientific decision-making regarding prenatal, perinatal, and postnatal management. The effect of the fetal anomaly on the physiological interaction between the fetus and mother is complex and variable, with a significant bearing on the outcome of pregnancy. These factors should also be accounted for in the management of such cases. Prenatally detected fetal anomalies constitute a challenging problem because of the following reasons: the wide spectrum of the disorders, hydronephrosis, heart disorders, hydrocephalus, etc., differentiation of transient physiological changes from structural anomalies, renal pelvic dilatation, ventricular dilatation, bowel dilatation, etc., variable significance and severity of the defect that require detailed evaluation like grading/detailed organ measurements, renal anomalies, lung anomalies, cardiac anomalies, possibility of evolution of the problem during the gestation, hydronephrosis, lung lesions, teratoma, etc., occurrence as a part of a syndrome/genetic disorder/association, trisomy 21, Potter's syndrome, Vactal association of vertebral, anorectal, cardiac, tracheoesophageal, renal, and limb anomalies, etc., where multiple anomalies can coexist. Findings like oligohydramnios, polyhydramnios, fetal hydrops, etc. could be secondary manifestations of an underlying anomaly, fetal obstructive uropathy, fetal intestinal obstruction, and fetal teratoma/major lung lesion, respectively. Decision on the need for further evaluation/fetal imaging. Fetal MRI/invasive fetal diagnosis. Amniocentesis/chorionic villus sampling CVS. Decision on the need for antenatal intervention/ex utero intrapartum treatment. Exit. Procedure decision on the need for termination of pregnancy in cases incompatible with life. Determination of the prognosis and parental counseling. Methods. This narrative review analyses current literature with emphasis on relevant guidelines and recommendations, with reference to the evaluation and management of prenatally detected fetal anomalies. The literature was reviewed in the light of the clinical experience and observations made with regard to the management of these cases. The databases searched for literature this narrative review included Embase, PubMed, Cochrane, and Web of Science. The studies analyzed were English language, peer-reviewed journal articles, particularly consensus statements and commonly followed guidelines. Institutional Review Board, as well as the Ethical Committee approval were not required. An effort has been made to break down the problem into its various aspects, including clinical challenges, investigative modalities, therapeutic options, and their appropriate use. The generally accepted principles in the treatment of usually encountered anomalies were reviewed thoroughly to simplify and tabulate management principles. An overview of the various clinical scenarios and a broad outline of the management strategies are presented here. Results: prenatal genetic testing. The availability and widespread application of maternal screening and prenatal genetic testing modalities have revolutionized the diagnosis of genetic, metabolic, and syndromic disorders. But the clinical application of these new techniques has presented challenges regarding patient selection, communication with patients, factual interpretation of results, analysis of benefit, as well as moral and ethical concerns. The methods employed for prenatal genetic testing, maternal screening, and fetal imaging are to be performed, interpreted, and communicated with diligence and caution. A brief summary of the applications of the modalities of fetal genetic testing, maternal screening, fetal diagnostic tests, and fetal imaging techniques is presented here. Prenatal sonological diagnosis. Ultrasound scan, USG, in the first trimester is helpful in accurate dating, diagnosis of twin chorionicity, and early diagnosis of major structural anomalies like anencephaly. Measurement of nuchal translucency, NT, on USG is a marker for fetal genetic and chromosomal disorders, neural tube defects, NTD, and cardiac anomalies. Second trimester USG is helpful to assess major defects of the heart, brain and spine, kidneys, abdomen, craniofacial region, limbs, etc. It is to be done between 18 weeks and 22 weeks of pregnancy. Detailed fetal imaging using 3D/4D USG, fetal echocardiogram, fetal MRI, and serial USG are indicated in complex anomalies. Fetal structural defects can occur with or without fetal aneuploidy. Therefore, all patients should be offered a second trimester USG between 18 and 22 weeks of gestation, plus or minus second trimester maternal serum alpha-fetoprotein AFP. Soft markers on antenatal sonology. What are they, and when should they be considered significant? With regard to the prenatally detected structural anomalies in the fetus on USG, it is imperative to recognize some of the abnormalities that are generally referred to as sonological soft markers. These findings should be reassessed diligently and interpreted carefully, as they can be markers or features of very significant pathology, in spite of some of them being benign findings on many occasions. These findings generally mandate a detailed anatomical assessment and systemic survey to confirm findings and evaluate other organs. Many of these findings require systematic follow-up based on the initial assessment of grade/severity, possibility of associated pathologies, and likelihood of complications. Some of these mandates additional testing like torch, toxoplasma, rubella, cytomegalovirus, herpes simplex, screening, and fetal imaging like fetal echo/fetal MRI, while others mandate invasive fetal diagnostic modalities. Many of these could serve as markers of genetic disorders like trisomy 21 or other causes of aneuploidy. They can also help to predict the occurrence of prenatal/postnatal complications like intrauterine growth retardation, IUGR, uteroplacental insufficiency, UPI, oligohydramnios, preterm birth, preeclampsia, need for cesarean, and stillbirth. The most commonly observed soft markers on prenatal sonology and their details are listed below. 1. Fetal pyelectasis/renal pelvic dilatation. Definition: renal pelvic anteroposterior diameter in transverse plane, APD, of 4 mm or more in second trimester, and or 7 mm or more in the third trimester. Pelvic APD of 10 mm or more is the criteria for definition of hydronephrosis. Fetal renal pelvic dilatation can be a transient physiological finding, but it can also be the sign of a major urinary tract disorder/marker of aneuploidy. A follow-up USG at 32 weeks of gestation should be performed. If the APD measures greater than 7 mm at 30-week USG, postnatal follow-up is suggested. A significant proportion of prenatally detected pelvic dilatation, especially in the second trimester, will resolve either prenatally or during postnatal life. A significant progression of dilatation during prenatal follow-up is indicative of a pathological cause. 2. Single umbilical artery SUA. Definition: the absence of one of the umbilical arteries, which occurs in 0.5 to 5% of pregnancies. This is an isolated finding in 60 to 80% of cases. Isolated SUA is associated with small for gestational age, SGA, babies, higher rate of placenta or umbilical cord abnormalities, and a higher rate of cesarean-due fetal heart rate abnormalities. It is associated with a higher risk of SGA, preterm delivery, pregnancy-induced hypertension, requirement of intensive care, and perinatal mortality. The findings should prompt targeted anatomical survey and growth assessment. 3. Thickened nuchal fold, NF definition. The thickening of the skin and the subcutaneous tissues on the posterior aspect of the fetal neck measuring 6 mm or greater before 20+6 weeks gestation. In fetuses with normal USG screening for aneuploidy in the first trimester, thickened nuchal fold in second trimester is the most important soft marker in the detection of Down syndrome. Karyotyping should hence be offered when thickened nuchal fold is detected. Even with normal karyotyping, targeted USG and fetal echo are indicated when a thickened nuchal fold is identified due to the association with structural defects, like congenital heart defects. For intracardiac echogenic focus IEF. Definition: a small echogenic spot inside the heart, most commonly seen in the left ventricle, having brightness equivalent to that of the bone. In about 90% of cases, it resolves by the third trimester. Isolated IEF are associated with an increased risk of Down syndrome. The presence of an IEF is not an indication for invasive procedures in low-risk populations for aneuploidy. In the presence of negative first trimester screening, FTS/non-invasive prenatal testing, NIPT, IEF can be described as a normal variant. 5. Isolated ventriculomegaly, VM. Fetal cerebral ventricular dilatation. It is a dilatation of the lateral ventricle atrium to a width of 10 mm or more. Mild VM, 10 to 12 mm. Moderate VM, 12 to 15 mm. Severe VM, greater than 15 mm. Isolated mild and moderate VM is more likely to regress or become stable, unlike severe VM. It can be a normal variant or be associated with aneuploidy, genetic syndromes, primary brain abnormalities, congenital infection, and intracranial hemorrhage. MRI can be used for detailed evaluation of cases of VM, and torch screening is also indicated. The prognosis of VM depends on the severity, the presence of other abnormalities, and also an asymmetric pattern of VM. 6. Choroid plexus cysts, CPC. Definition: CPC is a small fluid-filled space greater than or equal to 5 mm within the choroid plexus, which is sonologically discrete, usually seen at 16 to 24 weeks of gestation. Isolated CPC is usually an isolated finding in an otherwise normal low-risk pregnancy and not considered as a structural or functional abnormality. CPC typically regresses by 23 weeks regardless of the underlying karyotype. Amniocentesis is indicated only if other anomalies, like those of trisomy 18, are present. 7. Echogenic bowel. Definition: fetal bowel of similar or greater echogenicity than the surrounding bone or fetal liver. 2/3 are detected during the first and the second trimesters. Echogenic bowel resolves spontaneously in 20% of cases. Echogenic bowel can be a normal variant and may also be associated with congenital viral infections like cytomegalovirus, aneuploidy, Down syndrome, intra-amniotic bleeding, severe UPI, meconium peritonitis, cystic fibrosis, anemia, and fetal growth restriction. It mandates detailed evaluation, including evaluation for cystic fibrosis, torch screening, and USG at 32 weeks to assess bowel obstruction. The likelihood of postnatal surgical intervention for intestinal anomalies is significantly increased if the finding is seen during the third trimester. 8. Shortened humerus and femur. Definition: bone length below the 5th percentile for gestational age. Shortening of the fetal long bones is seen associated with aneuploidy, skeletal dysplasia, fetal structural anomalies, preeclampsia, stillbirth, and IUGR. Shortened humerus and femur length may be an early sign of placental dysfunction. It mandates prenatal surveillance with serial USG for growth assessment and blood pressure monitoring. USG at 32 weeks is done to rule out skeletal dysplasia and to assess growth. 9. Absent or hypoplastic nasal bone. Definition: a nasal bone that is not visible in first trimester/nasal bone with a length of less than 2.5 millimeters in the second trimester. It is described as one of the phenotypic features of Down syndrome, but also has racial differences. The finding mandates a detailed evaluation of fetal anatomy. Microarray studies should be done in addition to fetal karyotype when the finding occurs with other anomalies on USG. The prognosis is good if there are no other anomalies and karyotype is normal. Soft marker screening is a tool in screening for non-aneuploidy-related conditions such as structural anomalies and adverse pregnancy outcomes that requires follow-up during marker in the setting of a negative non-invasive prenatal testing (NIPT) result. Discussion: the common management pathways of prenatally detected fetal abnormalities. The broad, general pathways in management only apply for the specific abnormality in isolation. The decision-making in complicated, multisystemic and genetic disorders are to be taken in consideration of the major, life-threatening anomaly as the key parameter on an individualized basis. 1. Fetal abnormalities that usually need prenatal follow-up and postnatal therapy. Renal anomalies like hydronephrosis, unilateral/bilateral, without complications like oligohydramnios and Potter's syndrome, unilateral multicystic dysplastic kidney/unilateral renal agenesis, isolated congenital diaphragmatic hernia and esophageal atresia, gastrointestinal anomalies like intestinal atresias, anorectal malformation, meconium ileus, enteric cysts and duplications, small and intact exomphallos/gastroschisis, tumors/cystic lesions like small sacrococcygeal teratoma, small lymphovascular malformations/cystic hygroma, benign cysts such as adnexal, ovarian, cysts and colodocal cyst, uncomplicated craniofacial/limb/chest wall abnormalities. 2. Fetal abnormalities that may require induction of preterm delivery. Ruptured exomphallos/gastroschisis, progressive hydrops fetalis, progressive hydrocephalus, progressive hydrothorax, arrhythmias like supraventricular tachycardia, severe IUGR. 3. Fetal abnormalities that need planned cesarean section. Large sacrococcygeal teratoma, severe hydrocephalus, large myelomeningocele, conjoined twins, large omphaloceal/gastroschisis, large cervical lymphovascular malformation/cystic hygroma, malformations that require preterm delivery in the presence of inadequate labor/fetal distress. For fetal abnormalities that may require an ex utero intrapartum treatment, exit procedure. Conditions that require emergency upper airway access like congenital high airway obstruction syndrome, chaos. Large cervical tumor like teratoma and mass lesions causing obstruction to the oral cavity/trachea, lymphatic or vascular malformations. Conditions requiring immediate extracorporeal membrane oxygenation, ECMO, cannulation. Thoracic/mediastinal mass lesion that prevents lung expansion. 5. Fetal abnormalities that are usually managed by termination of pregnancy for fetal anomaly. TOPFA. Severe neurological defects like anencephaly. Severe chromosomal anomalies like trisomy 13. Bilateral renal agenesis and infantile polycystic kidney disease. Severe metabolic disorders like Tay-Sachs disease. Severe and lethal bone dysplasias like recessive osteogenesis imperfecta. The essential principles regarding the evaluation and management of some of the common prenatally detected fetal anomalies is summarized here. Major congenital malformations are abnormalities that are severe enough to reduce life expectancy or compromise normal function. They cause neonatal death in more than 20% of cases. They are considered to be lethal if they cause stillbirth or infant death in 50% of cases. If newborn infant with major malformation cannot survive without medical intervention, then they are considered severe. The antenatal diagnosis of a fetal anomaly can lead to one of the following outcomes. Continuation of pregnancy, without the need for any further evaluation other than the routine follow-up scans. Applies when the anomaly detected is deemed to be physiological/mild with no perceived risk to the fetus or mother/no risk of worsening or complications. Continuation of pregnancy, with targeted serial follow-up scans/detailed USG assessment or grading to assess the evolution of the problem/involvement of other organ systems/complications like organ damage, Asterisk. Continuation of pregnancy with the need for further imaging like CT/MRI or fetal sampling when major congenital disorders are suspected, with the findings of evaluation having a significant bearing on the outcome. Asterisk. Continuation of pregnancy with the need for maternal/fetal intervention in occasional cases of treatable major disorders where the intervention is expected to reduce morbidity and mortality of the fetus. Asterisk. Continuation of pregnancy with changes in the timing and mode of delivery to improve the outcome of the fetus. Option of early induction of delivery/cesarean section. Asterisk. Termination of pregnancy for fetal anomaly (TOPFA) after counseling when a serious disorder that is incompatible with life is diagnosed sufficiently early in gestation. Asterisk. Delivery should be conducted only at an appropriate center, with maternal transport if required. The apt use of the techniques of maternal screening, genetic testing, first trimester USG screening, and diagnostic fetal testing would help in timely diagnosis and early detection of major fetal disorders and major structural anomalies, thus offering an opportunity for early termination of pregnancy. Similarly, the use of advanced fetal imaging and fetal sampling studies can help to assess the severity of the disorder in doubtful situations and also assist their follow-up. Though fetal therapy is not yet widely practiced, the detailed diagnosis and prognostication can aid in instituting the appropriate perinatal management. Conclusion. The evaluation and management of fetal anomalies poses unique challenges due to the variegated nature of the disorders and the wide spectrum of presentation. The distinction of minor physiological alterations from actual structural defects is crucial in this regard. The establishment of definite clinical practice management pathways for screening, diagnosis, and therapy are mandatory to bring clarity to management. Greater understanding of the natural history of these disorders, their evolution during gestation, and the effect on the mother, fetus, and the pregnancy are critical to the optimal management of these conditions.